Kia ora tātou, ko te ahumairangi te maonga, ko Atari te awa, no te whanganui tara ahau, no Ngāti Pākehā te iwi, ko Every-Palmer te whānau, ko Susanna toku ingoa, no reira tēnā koutou, tēnā koutou, tēnā koutou katoa. Today I'm going to talk about trauma and its treatment amongst people with serious mental illness in our forensic service down here in Wellington. So I want to start by acknowledging my co-authors who are listed here and all the people who supported us in this research in the clinical service, our data safety monitoring board, who Jackie Short, who's here today, was on as well, and Araputama Corrections New Zealand. And most of all, I want to acknowledge the participants we had. So these were people who shared their trauma histories with us and trusted us with their most distressing experiences. And we know that this wasn't easy, and we really honour this contribution. And I'm going to start with a karakia to open the session. Whakataka te hau ki te uru, whakataka te hau ki te tonga, kia mā kina kina ki uta, kia mā taratara ki tai, e hi ake ana te atakura, he tio, he hoka, he hauhu, te hei Māori ora. So trauma and PTSD in people with psychotic disorders in forensic settings. And when I'm talking about forensic settings, I'm talking about people who are accessing mental health care either in custody, in secure inpatient facilities, or in the community. And what we're going to chat about is recognising PTSD as a common comorbidity in this group. Now, my big take-home point is that I know that everyone who's watching realises how prevalent trauma is amongst the people that we're seeing, researching, or working with in forensic settings. But what we found in our study, and actually what I guess precipitated the study, was the realisation that we didn't manage it very well. So although we recognised it, we often failed to really appreciate the ongoing daily effects that that was having on people's lives and to offer evidence-based effective treatments for it. We conducted a real-world RCT of EMDR, and I'll talk to you about that. That's the second topic, for PTSD in adults with psychotic disorder, and a qualitative study of their lived experience of receiving this treatment. So this is the first topic, recognising PTSD. And we'll talk about PTSD as a condition, its relationship with comorbidities and in forensic settings, and a bit about the participants that we were studying. So this is just a reminder of the definition of PTSD. You need to have been exposed to something pretty awful, actual or threatened death, serious injury, or sexual violence. And then the re-experiencing phenomena that come with that. Intrusive symptoms such as memories, dreams, dissociation, feeling distressed. Avoidance. This is a key that makes it hard to recognise and treat sometimes, because people really don't want to talk about this awful stuff that's happened to them. Or sometimes, you know, as with our patients in forensic service, this awful stuff that they were responsible for. The negative cognitions and the mood that's associated with the trauma, and then the alterations in arousal and reactivity. So feeling hyper-aroused, unsafe, reacting towards things. So no surprises that trauma syndromes frequently present with comorbid serious mental illness. And, you know, this is very commonly psychotic disorders and major mood disorders. Because we know from the evidence there's a tri-directional relationship between trauma, mental illness, and incarceration as well. And the evidence of a nexus between trauma and the development of psychosis. So these adverse childhood or early adult experiences that can then lead through a common pathway to development of serious mental illness, maybe substance abuse, and coming into the attention of the criminal justice system. Now, when I present to a more general population, I had a lot more in my slides about the epidemiology of PTSD in forensic environments. But I've taken that out because I know that you guys already know this. This is something that you've experienced yourself firsthand and you've seen, and there's no surprises here. So looking at the New Zealand population in Australia is very similar. There's a lifetime prevalence of estimated around 6% of PTSD. But within New Zealand prisons, it's about a quarter of people. 24% of people meet the diagnostic criteria for PTSD at some times in their life. And then in forensic mental health patients, it's getting up closer to half, so 41%. And the costs of this is really high, both for the individuals and for society. So we know for people who have PTSD, they have significantly higher rates of suicidality, aggressive behaviour, including violence, and a risk of reoffending. And the untreated PTSD may serve as this ongoing stressor which aggravates symptoms of other mental conditions, typically psychotic or mood disorders, and or might predispose people to substance misuse. So this is Dave. He's a real person, but that's not his name or his face. And actually, as an interesting aside, it was very hard to generate realistic portraits of people in custody via AI, because AI was overly influenced by the hundreds of millions of people who were fans of the hot felon meme of 2015. So I don't know if anyone remembers that, but all our previous efforts seemed 98% based on Jeremy Meeks, who was the hot felon in question. And so that was really quite distractingly handsome when I was trying to present this. So we've tried to unmix him a little bit, but he still has particularly good bone structure, I think. But yeah, Dave was actually a middle-aged, previously relatively high-functioning man who had schizophrenia, and he was acquitted of a really awful index offence that had occurred over 20 years before I was treating him. It was a multiple homicide. 2 of the victims were his young children, and he was found not guilty by reason of insanity. And the genesis of this study was, at the time I was the clinical director of the service, and we were reviewing patients for special patient reviews. I know that you have equivalents in Australia, kind of like a parole board for forensic patients. And there was Dave and another patient who had both been doing, we thought, really, really well. Had in fact been discharged out into the community and were managing well. And then suddenly they represented having had, potentially catastrophic relapses. And for both of these people, Dave and the other client, this had been related to trauma, to undiagnosed, ongoing, active PTSD in which they had been triggered and then had quickly spiraled into this really maladaptive behaviour and a sudden and florid and quite dangerous psychosis. And I had been Dave's psychiatrist in the past. And although I absolutely knew about the trauma, I had missed the fact that he still had active and debilitating PTSD. His index trauma had been years previously, and he was extremely defended against talking about the trauma. He did not want to go there. He minimized it, because of the horror and the shame and the guilt. And in thinking about this, I realized that actually the service had been a bit complicit in colluding with this. because, for many of us, particularly those of us who had children who were maybe the same age as Dave's children when he had killed them, it was really hard to talk about this and to hold this, person who we viewed in positive regard and wanted to treat in mind with this awful thing that had happened. And so we too had kind of pushed it to the past, and we didn't go there and didn't really talk about it much anymore, apart from in the context of the SPR. So we thought that, the historical trauma was a significant factor, but we had underestimated how active and debilitating the ongoing post-traumatic symptoms were in people's daily lives. And for many people like Dave and others, there were multiple compounding traumas that they'd experienced. In terms of PTSD management, there's two psychological interventions that are endorsed by NICE guidelines, World Health Organization guidelines, and other treatment guidelines: trauma-focused CBT and eye movement desensitization and reprocessing. And these have the strongest evidence base to support them. They are in the general population pretty much equally good, and it can depend on patient preference as to which one might be employed. There's pharmacological interventions in which the evidence is significantly less strong and include antidepressants and sometimes antipsychotic augmentation of psychological therapies. But absolutely for PTSD, first line would be psychological therapy. For reasons that we will come to, we chose EMDR as the treatment that we were going to test in our setting. And so that's when the patient is asked to think of the traumatic event while tracking the therapist's hand moving back and forth, and the bilateral brain stimulation activates information processing pathways, enabling adaptive associations. And this, so the theory goes, leads to processing of traumatic memories into long-term memory. Now, I do not really understand how EMDR works. I've not been trained in it. I'm not an expert on it. When I started this research, I was a skeptic because it seems odd, right? Just seemed odd that it would work. But I am also, a scientist, and the evidence was very clear in the community studies that it was effective, and there had also been some high-quality RCTs published looking at EMDR having been used for people with PTSD and psychotic disorders, and so there was a good track record of it being safe. However, no evidence, no trials that had ever been done in prison or in forensic settings. And to me, that seemed pretty outrageous, right? Given the cost of trauma on individuals' lives and on society in terms of recidivism and mental illness and this very disadvantaged group, it seems really surprising that no one has ever done a clinical trial. As we got into the guts of the trial, I did start to realize how maybe some of my thoughts about how easy it might be would be were naive, but we did that nonetheless. So our study population were adults who were under the care of forensic mental health services, either in prison or in inpatient care. We had in our pre-study paraanalysis anticipated that we would need to recruit 40 patients. Unfortunately, this recruitment phase coincided with COVID, in which we could no longer access the prisons, and so we ended up terminating the trial when we'd only included 24 participants. However, as you will see, it was actually adequately powered. And we had 10 participants who were recruited to qualitative phase interviews. So what we found when we talked to our participants about the effect of the trauma that they'd experienced on their life is that they had experienced debilitating and enduring PTSD symptoms for years and sometimes decades, often on a daily basis, including arousal, reactivity, cognitive and mood symptoms. But shame and guilt were really strong drivers for people, and many of them had felt unwilling or unable to discuss their experiences with their treating teams. Most of these people had, individual psychology at different times, and they'd all had psychiatrists, but there was a real barrier to talking about this. And fewer than half of them had ever been diagnosed with PTSD, although all of them absolutely met criteria for PTSD when we examined them using structured interviewing. And this key first theme was that they felt that they had been seriously messed up by trauma. So talking about not sleeping well, re-experiencing phenomena, and the effect that it had on their ability to engage in relationships and trust other people. And many talked insightfully about the relationship between the traumatic things that had happened and their reactions to those, and the ongoing mental distress. So this person saying, I think that's where the voices stem from. Others associating their edginess and high levels of arousal and reactivity with paranoia, lack of trust, and sometimes violence. And many of them were or had been at different times using substances to cope with some of their experiences. They had, some of them tried treatment. This had included psychological therapies, mainly CBT based, and different medication. The vast majority of all our patients were on antipsychotic medications, but there was an array of medication that people had tried. But the general feeling was that these treatments might have dulled some of their symptoms, but certainly hadn't alleviated them. And some of our participants talked about how their reluctance to trust people was also impacting on their therapeutic alliances with therapists, psychologists, psychiatrists. So talking about how it took time to trust people, keeping people at arm's distance, or being wary of personal and professional relationships. So from that first phase, it's very clear in the evidence that PTSD is extremely common. Probably about 25% of people who are in custody, and half of those who are in forensic services, higher even in women than in men, that there is this tri-directional relationship between experiencing trauma, developing mental illness, and being incarcerated. And many of our participants also talked about being re-traumatized within forensic or custodial settings, and feeling seriously messed up the trauma continue to have major impacts on their lives. So when I was putting these slides together a while ago, I came across this in my newsfeed, and it had a very clickbaity title. But once you get through the first couple of paragraphs, it was a not uninformative piece about EMDR, mainly about Prince Harry having EMDR. So is it another fad or does it work? Well, I'm going to present the results from our trial in which we will answer the question, does it work for our forensic patients? And there's a few key points that I'm going to emphasize just before we get into the guts of it. So I've said it was a real world RCT. And by this, I mean that we recruited all the people that were available within our forensic service who had PTSD and psychosis. So they're the sort of people that if you're working in mental health services or prison, you'll be working with on a day-to-day basis. They had schizophrenia. The vast majority of them had substance use difficulties in the past, comorbidities, personality difficulties. You know, some of them were on benzodiazepines, which are sometimes contraindicated or thought contraindicated for receiving EMDR. They had been people who had dropped out or disengaged from previous treatment. They had serious forensic, offending histories, and they had psychotic illnesses, and some of them still had low-grade psychotic symptoms, although generally those illnesses were being actively managed. So we didn't have everyone was competent to consent, but there was still, quite significant ongoing psychopathology. So these are the guys that don't get into clinical trials very often because they're not, the perfect and very responsive patient. So it was a very much a real world population because we wanted to know, would this treatment work in our real world? And I've said as well that doing this, we were screening people for PTSD. We screened all agreeable inpatient service users. And what we found is what I emphasized before, that PTSD was very common amongst our client group, but historically we actually hadn't been great at recognizing it. So of the people that we screened, almost all of them had some PTSD symptomatology, and around 1/3 of our forensic clients fulfilled the DSM-5 criteria for PTSD and hence were eligible for the study. However, despite all the intensive care that they'd been receiving, a lot of this PTSD had not been previously diagnosed. So fewer than 50% of them had PTSD diagnoses on their clinical file. So I strongly encourage people to think about undiagnosed PTSD in their client group. And then, as I mentioned before, those of us who were leading the trial, we weren't fans of EMDR. And by that, I mean, we weren't invested, we weren't EMDR practitioners. I'm not trained in it, I've never had it. As I said before, I was a bit skeptical about it. We just wanted to know whether this could be something that works. So we came from a very neutral position of, would this be helpful? But don't worry, we did have experts administering the treatment. So this was led by Tom Flewitt, who I'd say was New Zealand's expert in EMDR, working with people with psychotic illnesses as well. So we delivered high quality EMDR, but those of us leading the trial, we weren't really invested in an outcome of proving EMDR worked. We were just interested in whether it would. there was a lot of anxiety in our service amongst staff, and Jackie, who's listening today and works in our service, will remember this as well. And it was certainly very prevalent in the prison that maybe if we reminded people of their traumatic experiences, they would decompensate. And so there was this question about whether EMDR would be safe. It was a real issue trying to get ethical approval to run this trial involving people in custody, because they were worried about suicide risk. And so the basic position would be, it would be better not to go there, not to try and treat PTSD, because who knows what would happen if you did. In terms of this slide here, I didn't watch the TV series which shows Prince Harry having EMDR and reciting London as a trigger, and maybe he needed to say something to make it more engaging television. But actually, one of the advantages of the EMDR therapy is the patient does not need to talk. They don't need to share their experiences. And in forensic psychiatry and often elsewhere, people don't want to. So this was not so much a talking therapy for them. It was more of a processing therapy. And you'll see a little bit later on what our clients said about that. So this was the methodology. Single blinded. The assessor was blinded. So that was the person who was measuring the outcome measures. I don't know if anyone in the room has run a randomized controlled trial before. This was the first time that I had done it, and I had been worried that it would be difficult, expensive, and time-consuming. It wasn't that difficult. Doing an RCT is a bit like following a recipe. So you write your protocol and then you truck along. And it wasn't actually that expensive, because it was a way of systematically testing the resources we might have been using anyway in the clinical setting. So our lead therapist, he was paid clinically to be administering this therapy. But it did take up a lot of time. And the big challenge was recruitment. Both the difficulties with getting staff on board, particularly in prison, reluctance people had about their patients and being involved in the therapy because of what they saw as potential risks, and also COVID getting in the way of that. These were the sites that we recruited from: 2 adult forensic services, a female prison, that's top left, and men's prison in the bottom right. And we were very keen to include people within the prison setting, because in New Zealand, as in Australia, we have an inadequate number of forensic inpatient beds. So we're commonly treating people who are very unwell within the custodial setting. Yes, this was the fear that corrections had about letting us in, that once we took the lid off the can of worms, people would become very unwell. And so we were only allowed to recruit people who were receiving active forensic case management in prison. So if there was any concern about risk, they could be seen quickly by their forensic team. And that also limited the number of people we could recruit in prison as well. And we needed to compare EMDR against a control of treatment as usual, because of the concern that EMDR could in fact make people worse. So we compared EMDR therapy to treatment as usual, and the treatment as usual, especially in the forensic setting, was pretty comprehensive, right? So people were getting all sorts of multidisciplinary input: cultural, social worker, psychiatry, psychology. The only treatment that they weren't allowed is they weren't allowed to be receiving EMDR at the same time from another provider. And we were looking at the efficacy of EMDR, the safety of EMDR, and we were interested in what people thought about it, what their lived experience of EMDR was. And we had some secondary aims looking at its effects on psychotic symptoms, social functioning, self-esteem, and depressive symptoms. We did not expect those measures to be adequately powered, but we thought it would be helpful for informing future studies. These were all the different measurements that we were collecting, and we had a really good, extremely patient psychologist who went through and collected all the outcome measures with participants. And here's our participants, all between 18 and 65. And to be included, they all had to meet PTSD criteria determined by the clinician-administered PTSD scale, which takes about 40 minutes to complete. We'd published the protocol beforehand, which was actually very useful when I said that doing an RCT was like following a recipe. This was the recipe that we then followed. We screened 80 people for inclusion, and 26 of them were CAPS positive, and 24 of those were randomized. Now, one thing that I've taken away from this study that I use all the time now in my clinical practice or when I'm doing court reports is this trauma screening questionnaire. Because as I said, the CAPS takes about 40 minutes to do. So what we did was we first screened everyone with the TSQ. And this only takes about 1 minute to do. And if people scored positively on the TSQ, they were then referred for the comprehensive CAPS screening. So I found this really excellent, actually, for being able to move from understanding that people had trauma in their life to quantifying how much it was affecting them. If I'm trying to do a quick forensic assessment and I want to make sure that I am covering the effects of trauma. So I've put that out there as well, because I'm also recommending this to my registrars as a useful and quick trauma screening tool. And it's asking whether people have experienced any of the following at least twice in the last week. In terms of our methodology, obviously you can't do a double-blind trial of EMDR, because people know if they're watching somebody's finger tracking back and forth, and the person who is delivering the treatment also knows that they're doing it. So we blinded our assessors and we blinded our statisticians, and that was as much blinding as we were capable of doing. The EMDR that we used was very standardized. It was according to Shapiro's 8-phase standard protocol. Each session was 60 minutes long. Now, in the wild, if you are administering EMDR, you wouldn't administer it in a prescribed dose of 9 sessions. But because we needed to standardize it for the purpose of the trial, that's where we cut off. People could they could respond faster than 9 sessions, but they couldn't have more than 9 sessions for the purpose of this trial. And this is just a quick summary of our participants who reflected New Zealand forensic population, although slightly boosted for women. 33% of our participants were women, whereas actually it's under 10% across our broader forensic services. And as I've mentioned before, only half of them had previously been diagnosed with PTSD, although they all had active and active PTSD that was seriously affecting their daily life. And we also had people coming in and observing the sessions to see if they had, what the fidelity was to the standard treatment, and that had a very high, good adherence to the standard treatment, meaning it was EMDR as you see it in the tin as it's prescribed in the book. It was standard EMDR. So these were our primary outcomes. The first one was looking at the CAPS. So this was PTSD symptoms. And what we see here is that the CAPS was significantly better in the EMDR group than in the treatment as usual group. And we were surprised by the strength of the relationship by the effect size, because we hadn't reached our target recruitment. But if you were treated with EMDR, your CAPS score reduced by 11.4 points compared to not receiving EMDR, and that was a significant difference, so a clinically significant difference. At T6, which was 6 months, 16.7% of the EMDR participants still had their diagnosis of PTSD, and that compared with 36.4% in the treatment as usual group. What about fears that people might decompensate? Well, fortunately, these weren't realised. EMDR was well tolerated. No participants experienced serious adverse events. In terms of the secondary outcome, this was also surprising because we thought we were well underpowered for this, but people treated with EMDR were significantly less disabled, they were less depressed, and they had better self-esteem. The difference in psychotic symptoms was not significant, but the trend favoured EMDR. And that paper has been published, and that's the reference for that one. I might just move on to that, to the participant experiences. So lastly, we looked at people's lived experiences of EMDR, and there is data, qualitative data reported elsewhere in non-forensic settings, looking at EMDR as an enabler of change. But none of the studies included participants in the following group: people with psychotic disorders, people in any form of inpatient mental health care, people receiving any form of forensic mental health, or people in prison. We did 10 interviews amongst participants who'd received EMDR and used thematic analysis. And the key theme here was the same as the one that I had: early skepticism. So people used epithets like, I was pretty sure it was rubbish, or quackery, or mind control. Our participants, most of them hadn't heard of EMDR, and when they did hear of it, they really weren't convinced that it would help. There was low pre-treatment expectations. Some of them were scared about it. Why did they agree to participate? I think there was the sense that they recognized they were being significantly affected, and they thought they would give it a go. I was sort of curious to where it would lead. It was hard, especially at the beginning. So the participants talked about the fact that this did bring up uncomfortable feelings and emotions. It was scary. And that they felt exhausted afterwards was quite a common thing after they'd had a session. But the majority of them said that even, you know, 1 or 2 sessions after starting EMDR, they were starting to notice positive differences, and that made it worth persevering. And then this really strong theme was, and it worked. So despite their low expectations, people were often blown away by the fact that for them, EMDR had a real positive input. And you know, I love this quote from this guy who, I did the interview for him, and he was in prison, and he said, I rang up Mum and I said to her, guess what? I'm in a bloody good mood today. And she said, what have you done? Are you all right? Are you taking drugs? I was like, I don't know, but I think it's got something to do with this guy waving his hand up in the air. So it was like a light bulb has gone off in my head, and I thought, wow, holy shit. Participants really found EMDR very helpful, and quite a transformative change. Now, there were 2 people, so of those that we interviewed 10 of the people from the EMDR group, and we tried to recruit, we did recruit the one person who dropped out of treatment early because we wanted to know why they hadn't found EMDR beneficial. They didn't like it because they said that they just wanted to push the trauma to the back of their mind and not talk about it, and it felt like EMDR was bringing it forward. So they did not have a positive experience. That was one person, and one person had a more nuanced experience, some positives and some not, and 8 of them found that it was significantly beneficial. And a key theme was that EMDR gives you the power. It was suited to the forensic setting. So this other client talked about having to go through therapy for, you know, reports to the parole board and elsewhere, and saying that he just had to lie his way through because he was always so conscious about trying to put himself in the best light. So he felt with EMDR he could do that within his own head without having to reveal all these difficult things to other people, and that suited him very well. So overall, what we found was that people had felt that in the past, the pressure to demonstrate this requisite success in therapy led them to often, you know, feel that they needed to be dishonest or overinflate the positives, leading to some resentment and limiting therapeutic gains. In our services, recovering from psychotic symptoms may be comparatively straightforward, but actually the grief and distress around the index offence can persist for much longer. The desire to seek help for trauma symptoms can be complicated by grief, guilt, fear, stigma, often related to the social taboos around the causal events. And with EMDR, the pressure to say this right thing was relieved, so people felt that they could engage more authentically without shame or fear of negative appraisal. Overall, some of our limitations, you know, the fact that we'd only had 9 sessions and the relatively small sample size, and this is the publication reference for the qualitative study. So in conclusion, what we found was that PTSD was extremely common amongst our client group. that EMDR was an appropriate treatment for them, and that people themselves considered it effective and acceptable, and that its benefits were considered to extend beyond PTSD symptoms to improve self-esteem. So should be considered as a treatment for PTSD with serious mental illness, and this is starting to be more commonly offered across forensic and also custodial sentences.
Thanks very much, Susanna. That was fascinating, and it's really wonderful to hear some good news. We have a lot of the research that our group does is descriptive epidemiology, and it's describing problems. So it's wonderful to hear some strong evidence of something that's actually creating some benefit for people. So thank you so much for that. And we do have time for a few questions. Lindsay, please go.
Thanks, Susanna. That was really interesting. I'm just wondering, based on the really positive findings of the program, are there plans to roll that out further in other facilities? I can imagine, just from what we know in Australia, there's just really not enough funding and capacity for mental health supports in prisons. Is that this similar in New Zealand?
Absolutely. There's absolutely the case in New Zealand. Having said that, Te Ara-Putama, who are our, correction service, are interested in EMDR because they see it as cost effective. So the idea that you could have fewer than 10 targeted sessions, plus they've been interested on the basis of this research as well. So they've been looking at and have started training up more of the prison psychologists to be able to administer EMDR, and also thinking about group EMDR. So we're not there yet, but it feels that that's a direction that we might be traveling in.
That's good to hear. I'd wonder if anyone else in the Australian context has any thoughts around how likely it would be that something like that would be of interest to departments of justice in this country.
I see that we have an aspiring clinical psychologist who's about to start working in prisons. And Eva, you might be able to respond to that and probably have a question as well.
Well, I was just going to ask because I've been doing work in Department of Communities and Justice here in New South Wales with children in out-of-home care, and typically they often have PTSD as well, by way of being removed from parents and I guess other experiences in the out-of-home care system, and the trajectory of them then having contact with the justice system has increased. Did you, whilst the people in this study didn't talk specifically about their traumas, was there a sense of what the trauma was? Was it a childhood trauma that they'd experienced a long time ago, or, were they could have been prevented?
Super question. So we did do the LES, I think it stands for the Life Event Scale, on people, which looked at all their traumas, and they had an extremely high score on that. So one of our participants had one trauma, and that was when she killed her dad in a psychotically induced state. That was her only trauma. Every other participant had multiple traumas across their lifespan, as we might expect, right? So they had accumulated, a whole range of adverse childhood experiences, often including sexual abuse, and then that trauma had continued to accumulate across their life. I had expected that for my female patients, because my female patients had often been talking about that, but the trauma burden in the male patients was just as high as in the female patients, but it was often something that they hadn't been talking about as much. So yes, absolutely, it was multiple traumas, and for the study we selected the nominated most distressing trauma for people, but obviously you could have kept doing EMDR and processing all the different traumas as well.
Great, thank you. It's so fascinating to see the evidence of this, because I similarly, I've not done EMDR training, but I'm definitely skeptical. But people I've worked alongside have said it's as part of the training, you actually experience EMDR yourself, mainly because there is a lot of skepticism from clinicians, and they say it's amazing the difference that they have when they experience it, and then they really believe in the efficacy of it.
Yeah. One thing that I thought interesting about doing the RCT is, for me, it was harder to believe the numbers than it was the people. And so even, you can look at the evidence and you can see that EMDR has a strong effect size. But actually talking to the person who'd been in prison, who told me that story about ringing up his mum and his mum saying, "What's going on for you? Are you on drugs?" You know, and his relaying of that has had a more powerful effect on convincing me that EMDR was an effective therapy than even looking at the numbers. So that's an interesting way to think about how human biases work, right? Because we are swayed by that personal experience.
Yes, having the numbers and the lived experience is pretty compelling. Look, I see Graham had a related question in the chat. Graham, do you want to just unmute and fire away? You're still on mute, Graham.
Okay, hopefully you got me now. Thanks, Susanna. Brilliant presentation. Thank you so much. So two questions. One is really about the challenges in identifying the traumatic events for the participants. How easy or hard that was, just given that most of the the tendency is for people who have PTSD is to sort of avoid discussing it or trying to repress it. And I got, obviously the second one is actually how far away is it from publication?
Yeah, thank you, Graham. Good questions. It's funny, isn't it, that when you ask people, they'll often tell you stuff. And I'm constantly surprised by this. One of my first research papers was looking at synthetic cannabis in our service. And people had all started smoking it, but the staff didn't know what it was. But all the patients did. And there'd become this kind of conspiracy of patients picking up this, herbal incense stuff and then smoking it. And I did a study on it, in which I was a clinician in that service, and I went around and I asked all the patients about it, and as part of a research study, and they all said, "Oh yeah, we've been smoking this stuff for ages. You guys don't know anything about it. You're really stupid." And I was staggered that they were telling me that, because then, of course, we stopped them smoking it. But it is interesting that if you approach people and ask directly about things, they'll often tell you things that they wouldn't have brought up themselves. And that's why I think a bit we'd been colluding by not answering the questions. Like, the clients didn't want to tell us, and we sometimes weren't comfortable asking about it. Of course, there may be many people who opted not to participate in the study or participate in screening, or didn't tell us the truth, in which we didn't pick up their PTSD symptoms. But the vast majority did. So, I mean, it is often helpful to have standardized screening tools that you use and you practice with and you become comfortable with, and you just make the person feel safe that you're asking those questions. So that wasn't difficult. In terms of the publications, we've had 3 papers that have been published, and we've got 2 more papers that are still to be published. So the high-level findings have been published from the RCT and the qualitative study, and then we've got ongoing work looking at attitudes from staff, and also barriers to participating in the trial, and around some of the issues about picking up and treating PTSD. So some of the more affiliated work is still yet to come.
Thank you so much. I'm really interested about the attitudes, because I guess from our experience, one of the challenges often particularly within a prison environment, is that concept about treatment versus punishment, and that idea how that, you know, we almost tend to want to have secondary punishment, if you like, by withholding treatment from. So yeah, very interested about the attitudes.
That's a great comment. And when we first submitted our paper for publication, which was on the RCT, it went out for review, and a reviewer came back, an American reviewer, recommending it was rejected. And the reviewer's argument for this was that by definition, the people who were included in our trial could not have PTSD because many of them were the perpetrators of the trauma. You could only be a victim to have PTSD, and therefore they didn't have PTSD, and our trial was kind of a moot trial because the PTSD wasn't real. So, I mean, that was staggering to us, knowing, you know, that the people that we'd been working with, many of them who'd been acquitted on account of insanity, had done these things which just had completely ruined their lives, and which were very ego-dystonic, done well, unwell, and then being treated for their psychosis and having to realize the extent of what had happened. And this attitude that, you know, they couldn't have PTSD because they weren't the victims seemed extraordinary to us. But the journal accepted that and rejected the paper the first time round.